Hi, in this video, we're going to talk about the pharynx. Remember that the pharynx goes from the inferior part of the skull all the way down to the level of the esophagus. I'm going to show you a color picture of that. So remember that the oropharynx is from the base of the skull to the soft palate, whereas the oropharynx, so nasopharynx here, oropharynx here from the soft palate to the epiglottis, and then the laryngopharynx is posterior to the larynx from the epiglottis down to the inferior border of the cricoid cartilage. It's this region, posterior region shown here in pink, continuous with the epiglottis, where the larynx is anterior, and the buccopharyngeal fascia that we talked about previously is in this dark maroon color, and that is the anterior border of that retropharyngeal space subdivided by the alar fascia. So let's take a closer look at the pharynx, and in this image it is a posterior to anterior view of the pharynx, and this right side is a more posterior view than the left. So the muscles that make up the pharynx are the superior constrictor, shown here, and the superior constrictor comes together at this pharyngeal raphe or line. The pharyngeal basilar fascia sits anterior to that, just posterior to the mucosa on the inside of the pharynx. So between the superior constrictor and the middle constrictor, shown here, so this is the middle constrictor, between the superior and middle constrictor is a muscle called the stylopharyngeus. That is a good landmark for distinguishing between the superior constrictor and the middle constrictor, which sometimes can be difficult to do in gross dissection. The inferior constrictor has two parts. This more superior part of the inferior constrictor is the thyropharyngeus part, whereas the inferior part is this cricopharyngeus part where my pointer is here. What's important about that is that the cricopharyngeus part of the inferior constrictor serves as the upper esophageal sphincter. And so that muscle, that cricopharyngeus part, is tonically closed, preventing kind of the backflow from the stomach and digestive enzymes from bubbling up, so to speak, into the pharynx. And so when the action of the tonic contraction of that portion of the inferior constrictor is impaired, you might see GERD, that reflux disease, whereby those stomach contents are going more superior than is typical. The blood supply to the superior and middle constrictor are via the ascending pharyngeal branch, and that comes off the external carotid, right near the bifurcation of the external carotid with the internal carotid on the posterior side of it. And so the ascending pharyngeal artery is shown here, and it is often helped out or often assisting the ascending pharyngeal artery is the facial and lingual arteries, which may also provide some branches to the superior and middle pharyngeal constrictors. For the inferior constrictor, blood supply is often via the inferior thyroid artery, which comes off the thyrocervical trunk, and the superior thyroid artery, which is a branch off the external carotid artery. Also in this image, you see some nerves, and so this nerve right here is the glossopharyngeal nerve. Notice the glossopharyngeal nerve kind of wrapping around the stylopharyngeus muscle. That's a great landmark to make sure that you're distinguishing it, for instance, from the hypoglossal nerve, which can sometimes be confused with it. The hypoglossal nerve usually moves anteriorly in a more inferior position than the glossopharyngeal nerve. But if you find the stylopharyngeus muscle, that may help you to identify the glossopharyngeal nerve relative to the hypoglossal nerve, which is shown here. So on the right side of the image here, you can see the internal jugular vein coming through the jugular foramen. And remember that the jugular foramen also transmits, or the cranial nerves 9, 10, and 11, or glossopharyngeal, the vagus, and the accessory nerve are also transmitted via the jugular foramen. And so you see those entering into the neck or descending in the neck next to the internal jugular vein. And the vagus, as you'll see, branches of the vagus nerve, which is held in that carotid sheath between the carotid artery and the internal jugular vein. The vagus nerve is responsible, or branches thereof, for the innervation of the majority of the structures in the of the pharynx. Notice also the superior cervical ganglia shown here. Remember that superior ganglia will be the largest of the cervical ganglia, and it's easy to confuse that sympathetic ganglia with the nodose ganglia of the vagus nerve. So be aware of that. So this is a picture from Rowan, and you can see the pharyngeal basilar fascia superior here at the base of the skull, and then the superior constrictor immediately following that. The superior constrictor and the middle constrictor are shown here, and you can see that sometimes they can be difficult to distinguish from one another, which is why you want to take a look at that stylopharyngeus muscle, which helps you to distinguish between the two. Another way to distinguish them is their anterior attachments, where the superior constrictor attaches on a pharyngeal, a line, a fascial line just posterior to the buccinator muscle on the in the cheek, whereas the middle constrictor attaches on the hyoid bone. And so those can also serve as ways to distinguish between those two muscles. The superior cervical ganglia, again, is shown here. And then here's the inferior constrictor with the cricopharyngeus part, and the esophagus inferior to that. Just as I was mentioning a second ago with the anterior attachments to those muscles, you can see here the superior constrictor attaching to this pterygomandibular raphe, or line, this fascial line that exists posterior to the buccinator. Remember, the buccinator is a muscle of facial expression that we saw when we were investigating those on the anterior face. The middle constrictor is shown here, and it attaches on the hyoid in part, and the stylohyoid muscle is here. The stylopharyngeus muscle, the distal attachment of that stylopharyngeus muscle is between the superior and middle constrictor, which is why it helps you to identify that. The thyropharyngeus part of the inferior constrictor is shown here, and then sitting on the posterior part of the cricoid cartilage is that cricothyroid part of the inferior constrictor, cricopharyngeus part, excuse me, of the inferior constrictor, which is where it gets its name. So one part sits on the thyroid cartilage and attaches to it, and one part sits on the cricoid cartilage and attaches to it anteriorly. Also visible on here is the cricothyroid muscle, and the cricothyroid muscle sits on the anterior part of the cricoid cartilage and thyroid cartilages on top of the cricothyroid membrane, and is one of the muscles that acts on the vocal folds of the larynx. Now, important landmarks here would be also this thyrohyoid membrane that exists between the hyoid bone and the thyroid cartilage. The internal branch of the superior laryngeal nerve pierces this membrane in order to provide sensory innervation inside the larynx above the vocal folds. And so the landmark for the internal branch of the superior laryngeal nerve, or the internal laryngeal nerve, is this piercing of the thyrohyoid membrane. The external branch is motor, and it innervates this cricothyroid muscle that's on the anterior part of the cricoid and thyroid cartilages. Its action pulls the thyroid cartilage anteriorly in order to increase tension on the vocal folds, the vocal cords, which results in being able to hit a high note, for instance. Now, these branches, the internal and external laryngeal nerves, these are branches of the vagus nerve that came through the jugular foramen, is traveling inside the carotid sheath, and along the way it gives that internal and external branch, in addition to some pharyngeal branches that service the pharynx. Let's see, here's the glossopharyngeal nerve wrapping around the stylopharyngeus muscle. Again, notice that the glossopharyngeal nerve, its anterior path is more superior than that of the hypoglossal nerve, which we visualized in the when we did the submandibular area. Notice the hypoglossal nerve goes over this hyoglossus muscle, and then goes deep to the mylohyoid, and that can help you to identify the hypoglossal nerve. Now in this image, this is a posterior to anterior view again of the pharynx, but this time the pharynx has been opened up so that what you're looking at is the mucosal surface of the inside of the pharynx. And from there, you can view the nasal cavity, the oral cavity, and then the opening to the larynx. Here deep to the inferior to the epiglottis. And so in this view, you can appreciate these this ring of tonsils that are immune tissue that surround the openings to these different spaces, cavities within in the pharynx. So we'll start here more superiorly with the pharyngeal tonsil. And the pharyngeal tonsil sits on the base of the skull. The pharyngeal tubercle is right here. And the pharyngeal tonsil is what is hypertrophied, and we call that adenoids. So what hypertrophy of the pharyngeal tonsil can do is occlude the choana, which are the posterior openings to the nasal cavity, which results in mouth breathing for the individual. And so, in addition to that, if this pharyngeal tonsil is hypertrophied, it can also impact the eustachian tube or the auditory tube, and the opening of the auditory tube into the pharynx is partially covered on top by a mucosal pouch or layer called this torus tubarius, and the tubal tonsil sits right there, but also a hypertrophied pharyngeal tonsil can also occlude this. So an example of that would be when my youngest son, Ian, was about 1 or 2, we would be downstairs in our room and we could hear him upstairs snoring, sounding like a 60-year-old man, and, you know, rattling the walls. And so he was mouth breathing. And the snoring was really bad. And then the other thing that we noticed was that when he was speaking, it sounded muffled, like it was like he was kind of underwater. And so like he wasn't really making the sounds exactly like we should. So we took him to the doctor and he had really bad adenoids. And once we got the adenoids removed, he was able to hear clearly, his speech improved, and the snoring went away. So that's one example of how that might also impact, or how that might look in a patient. All right, so we have the tubal tonsil, the pharyngeal tonsil on the pharyngeal tubercle, and then as we continue inferiorly, we have the palatine tonsil, and so this is the soft palate and hard palate here, separating the nasal cavity from the oral cavity. The palatine tonsil sits between a palatoglossal fold and a palatopharyngeus fold. We'll talk some more about those. It sits in its own fossa, palatine fossa, and notice the close approximation of the pharyngeal tympanic tube opening, which is just superior to where the palatine tonsil sits in the posterior part of the oral pharynx. And so the palatine tonsil, when we think of tonsillitis, that's usually what we anticipate being infected. And that jugulodigastric lymph node is where the infection from a tonsillitis might spread. The lingual tonsil sits in the posterior part of the tongue, the posterior 1/3 of the tongue. And it sits just superior to the epiglottis and the opening to the larynx in the oral cavity. And then inferior to that, you'll see these piriform recesses. So boluses of food that would be pushed posteriorly by the tongue would move around the epiglottis. The epiglottis helps to protect the airway. Those boluses of food would tumble down the piriform recesses to gain access to the esophagus. And so those would be together. So I'm showing you these tonsils on one side, and just know that they are also present on the opposite sides, forming this ring around the nasal and oral openings posteriorly as those passageways into the pharynx. Here's another picture of those. So the lingual tonsil is sitting here with the posterior 1/3. The terminal sulcus separates the anterior 2/3 of the tongue, which have in the oral cavity, which have a different innervation than the posterior 1/3 of the tongue. and it's the lingual tonsils are sitting in close approximation to that. You can also see the palate and then the opening to the choana, or the posterior nasal apertures, those openings into the nasal pharynx shown here. So if we take a closer look at the palate is made up of the palatine process of the maxilla and the horizontal process of the palatine bones. And then overlying that, or superficial to that, you will have these palatine glands and mucosa that act upon that. The hard part, or the anterior portion of the palate that's formed by those bones, is the hard palate, whereas the musculus, and the muscular part, and the soft part, or the soft palate, is posterior to that. The sensory to the hard palate is via the greater palatine nerve, and it goes through the greater palatine foramina. Foramen, if you remember back when we were discussing the trigeminal nerve, and the descending palatine branches in that pterygoid, as we went through the pterygomaxillary fissure in the infratemporal fossa, it was a doorway to this pterygopalatine fossa that had lots of different exits. The greater palatine and lesser palatine foramina were inferior exits to that space that the terminal branch of the maxillary artery went into. Nonetheless, the greater palatine nerve is sensory to the hard palate, whereas the lesser palatine nerve is sensory to the soft palate. You also see some attachments to muscles that act upon the soft palate, the tensor villi palatini, palatoglossus, palatopharyngeus. Those muscles are some of the muscles that act on the soft palate, and we'll talk again about those. On this left side of the image, it is a deeper view than on the right side of the image. In each case, these muscles, this palatoglossus, this palatopharyngeus, these muscles are covered in mucosa, and the mucosa has the same name, creating the palatoglossal fold or arch, or the palatopharyngeus fold or arch. And so when the mucosa is present, we refer to these as the folds, but if the mucosa has been removed, of course, then what we're referring to are those muscles. Now, the palatine tonsil sits in between these two structures that you may also see referred to as the pillars of the fauces. And so when you're thinking pillars, thinking that this palatoglossal arch and this palatopharyngeal arch really hold up the structure of the posterior portion of the oral pharynx, as it of the oral cavity as it leads into the pharynx. And so, the palatoglossal arch and the palatopharyngeal arch, these folds are pillars nestled right in between there as the palatine tonsil. Look up the information in your textbook on deglutition or swallowing. I won't cover that. It's only a couple of paragraphs, but the movement of this soft palate is important in the movement of that bolus of food that's been chewed up in the mouth as it pushes posteriorly into the pharynx. Now, when this palatine tonsil, when we talk about a tonsillectomy, we're usually talking about the removal of this palatine tonsil as it sits in this fossa created by these arches. And posterior to that is where the blood supply comes from, and there are tonsillar branches of the facial artery and ascending palatine artery. And so the removal of that, any bleeding that results from that, as that tonsil sits covered in this fascia, can result in some bleeding. Notice also, though, that the muscles that are also acting on this posterior pharynx are attached to the pharyngeal tympanic tube, which now has been, the mucosa, the torus tiberius, has been removed in this image, and the salpingopharyngeus muscle, this tiny little muscle here, is also no longer covered in the mucosa that it is covered in. These muscles pull on the eustachian tube, including the tensor villi palatini and the levator villi palatini. These muscles act on the pharyngeal tympanic tube, pulling on it, allowing for the equalization of pressure. So I had a tonsillectomy at like 35 years old when I had strep throat 5 times that year, and finally they decided that they wanted to remove my tonsils. It wasn't the surgery itself that was so painful, but rather day 5 or day 6, as the scab started falling, there was lots of referred pain to the ear upon swallowing. And some of that is because of the glossopharyngeal nerve that is providing sensory innervation to the posterior 1/3 of the tongue and the pharynx. So that shared innervation allowed me to really feel that pain after surgery in my ears. All right, so the palatine glands that were on the previous page, so those glands on the hard palate and soft palate, those are parasympathetically innervated. And so the facial nerve, parasympathetics associated with the facial nerve, you don't need to know that this is the superior salivary nucleus, but those preganglionic fibers of the facial nerve travel through the greater petrosal nerve, through the nerve of the pterygoid canal, which is this dark green here, to get to that pterygopalatine ganglia that we saw, that's in that space that we saw from the infratemporal fossa. From there, postganglionic parasympathetic fibers then travel to the palate via these palatine nerves. Likewise, they also travel to the nasal cavity to also provide parasympathetic innervation for the lateral nasal wall and nasal septum. So again, when we're looking at the hard palate, remember that posterior to that is the soft palate, and when we're swallowing, the palate, the soft palate, needs to move up and down to accommodate the movement of a bolus of food as it's pushed posteriorly by the genioglossus in part, so that it can then enter eventually into the esophagus via the pharynx. So the muscles that act on the soft palate in order to facilitate that would be the levator villi palatini, which would elevate the soft palate. And then deep to that is the tensor villi palatini. Now, the tensor villi palatini and the levator villi palatini both attach to the eustachian tube or the pharyngeal tympanic tube. They both attach there. And then the tensor villi palatini goes around the pterygoid hamulus to attach onto the soft palate. And so in doing that, it tenses rather than participates in the, I guess, more drastic elevation of the soft palate. And so here is the tensor villi palatini in purple and the levator villi palatini shown more posteriorly in yellow. This is a posterior to anterior view again, where you can visualize the choana or the posterior aperture of the nasal cavity, where you can appreciate these concha on the lateral nasal wall and the nasal septum. Also participating in the movement of the soft palate would be the salpingopharyngeus, which is cut in this image, attaches to the pharyngeal tympanic tube, and also the pharynx. And so the attachment there, of course, would allow for you to unpop your ears, for instance, when you're on the plane, when they're popping as you take a swallow, where the collective action of the salpingopharyngeus, the levator villi palatini, and the tensor palatini can participate in that. Palatopharyngeus is here and together. So it would, together with the palatoglossus, which we saw on either side of the palatine tonsil, here's the palatine tonsil, together they would narrow the fauces or narrow the space at the posterior part of the oral cavity. Their contraction would decrease the space between the soft palate and the pharynx and the tongue. So those muscles that act on the soft palate are innervated by the vagus nerve. You see an asterisk here because there is some debate here as to whether or not some of those fibers are also cranial nerve 11 or the accessory nerve, but I'll explain the discrepancy for that in a second. All of these muscles are innervated by the vagus nerve, with the exception of the tensor villi palatini, which sits more anterior than this levator villi palatini. So the cough reflex is innervated primarily by the vagus nerve as an attempt to clear, for instance, the passageways for air in the throat. The gag reflex, in contrast to that, the sensory is largely via the glossopharyngeal nerve. And then the motor innervation, where the to cause retching, for instance, would be largely via the vagus nerve. And so those two reflexes come into play as we're talking about the pharynx and the relationship between the pharynx and the oral cavities and the nasal cavities. So here is the accessory nerve shown here in green, ascending through the foramen magnum before it exits the jugular foramen in order to access the sternocleidomastoid and the trapezius. The vagus nerve has a cranial and caudal portion, and these caudal fibers of the vagus nerve ride with the accessory nerve for a bit before they separate again in order to rejoin the more cranial parts of the vagus nerve after exiting the jugular foramen. And so it's these caudal portions that are responsible for innervating the muscles of that act on the soft palate. And so the asterisk next to that is that there are some disagreements about the amount of contribution of the accessory nerve to the innervation of those muscles of the soft palate. All right, so now we'll move on into our discussion of the nose. So the dorsum nasi would be the bridge, commonly called the bridge of the nose. The tip of the nose is the apex. The base is what we call the root of the nose. The nasal septum and nares are here. And then ala means wing. And so this wing shape structure is shown here. The bones that participate in the formation of the nose include the nasal part of the frontal bone, the nasal bone, and then the frontal processes of the maxilla, shown here in blue. There are two cartilages that are the lateral or upper cartilages, and then two greater alar cartilages and one septal cartilage, which subdivides the cavities. If we take a view through via posterior rhinoscopy, what we're doing is putting a scope through the oral cavity to allow us to then view the choana, or the posterior apertures of the nasal cavity. So here are the, let's say, choana of the lateral nasal wall, the hard palate and soft palate, and those things are visible as we're looking through the posterior apertures into the nasal cavity. So here is what we would see, right? So here are the choana, and then projecting from the lateral nasal wall would be the middle and inferior concha and the nasal septum, so subdividing the two areas. The soft palate is here with the uvula, and then you'll see the torus tubarius, or mucosal outpouching that covers the opening to this auditory tube. So let's talk about the lateral nasal wall first, okay? Notice that multiple bones contribute to the formation of the lateral nasal wall. Those concha, the superior, supreme, shown where my pointer is, superior, and middle concha are a part of the ethmoid bone, and you'll see those as you're studying the bones. The inferior concha is its own bone, and then you also see the pterygoid hamulus, portions of the palatine bone. So here's the pterygoid, medial pterygoid plate, the palatine bone, the maxilla shown here in purple. Okay. Remember that deep to each one of these shell-shaped concha are meatuses, or spaces, and those spaces have different openings in them that include but are not limited to the sphenopalatine foramen. The sphenopalatine foramen communicates with the infratemporal fossa. So the terminal branch of the maxillary artery exits the infratemporal fossa, entering the lateral nasal wall through this sphenopalatine foramen, where it changes its name to the sphenopalatine artery. On the nasal septum, you still see participation by the sphenoid bone and the ethmoid bone. In addition, you also see the vomer here, the maxilla, and the palatine bone here. The nasal septal cartilage is here. And so if a person, for instance, is huffing chemicals or participating in inhaling illicit drugs, that can erode the nasal septal cartilage, for instance, causing the structure of the nose to collapse upon itself, creating a dip or a saddle nose that results. So the paranasal sinuses are shown here, where the frontal sinus is in yellow. Posterior to the frontal sinus, you'll see that sphenoid sinus in blue. The ethmoid sinuses, those ethmoid air cells, are between the medial walls of the orbit on both sides. And then inferior to that, you'll see the maxillary sinuses created these pneumatized spaces, mucosal lined pneumatized spaces within the substance of the maxilla. Remember that they drain rather superiorly in that the frontal sinus, anterior ethmoid sinus, and the maxillary drain through this hiatus semilunaris, which is deep to the middle meatus. And so that superior drainage of the maxillary sinus, for instance, makes it difficult for that sinus to efficiently and effectively drain, so that you could, if you have a sinus infection, it can make it difficult for that maxillary sinus to drain. The sphenoidal sinus and the posterior ethmoidal sinus drain through a different opening deep to the superior meatus, the sphenoethmoidal recess. And I'll show you a picture of that in a moment. All right, so remember the middle meatus is deep to the middle concha, the superior meatus is deep to the superior concha, and the sphenoethmoidal recess, which drains the sphenoidal sinus and the posterior ethmoid sinus, is posterior to the superior meatus. It is difficult to see a supreme concha in most cadavers. And so that represents a challenge there. Here's the pharyngeal tympanic tube, the opening to the pharyngeal tympanic tube right in the nasopharynx, in the posterior part of the nasal cavity. So here the concha have been cut away so that you can appreciate some of these openings and relationships between the lateral nasal wall and the paranasal sinuses. Remember that the nasolacrimal duct drains inferior to the inferior concha, so in the inferior meatus, so that you are swallowing those excess tears created during crying as they drain posteriorly and then get swallowed. The hiatus semilunaris is here, so this moon-shaped structure deep to the middle concha in the middle meatus is shown here, and you can see this little yellow probe going through that space. The sphenoethmoidal recess is posterior to the superior concha and is shown here. Now, as we talk about the blood supply, I want to remind you again that the sphenopalatine artery is, we saw the maxillary artery in the infratemporal fossa. The maxillary artery dove into this pterygomaxillary fissure, into this pterygopalatine fossa, and exited on the other side through the sphenopalatine foramen to be called the sphenopalatine artery. So that was a branch of the external carotid artery. Coming off of the internal carotid artery, the ophthalmic artery, part of the internal carotid artery, gave off these anterior and posterior ethmoidal branches in the orbit. And so those branches all communicated, the sphenopalatine anterior and posterior ethmoidal branches communicated with each other in Kesselbach's area, which was on the lateral nasal septum. And so, here are our anterior and posterior ethmoidal arteries contributing to the lateral nasal wall. Those anterior lateral nasal branches are these more anterior parts coming off of the anterior ethmoid here. There are a couple of small branches from the facial artery on the face, and they sometimes anastomose with each other. The sphenopalatine came through the sphenopalatine foramen and gave these posterior lateral nasal arteries off of the sphenopalatine. The other part is that the descending palatine, which also was a branch in that pterygopalatine fossa before the sphenopalatine was coming through the sphenopalatine foramen. This descending palatine artery branches into a greater and lesser palatine artery, and as it goes through the greater palatine foramen and lesser palatine foramen. On the lateral nasal wall, you also see a branch of the anterior ethmoid. So the internal carotid via the anterior ethmoid, giving us these anterior septal branches off of the anterior ethmoid. Also on the nasal septum would be these posterior septal nasal branches. These come off of the sphenopalatine artery. Terminating off the posterior septal branches is this extension that goes through a foramen called the incisive foramen. And so this branch that goes through the incisive foramen is the nasopalatine artery. As we're talking about the nerves, sensory to the nasal cavity will be via branches of the trigeminal nerve. Coming off of V1 would be, so that ophthalmic division, that first division of the trigeminal nerve, would be the anterior ethmoidal nerve, which gives us external nasal branches that pierce the anterior face on the nose, and then these lateral internal nasal branches that provide sensory to the anterior lateral nasal cavity. The lateral posterior superior branches and lateral posterior inferior branches are branches off that second division of the trigeminal, which is the maxillary nerve. On the nasal septum, there are medial internal nasal branches, again off the anterior ethmoidal nerve, and then those are part of V1. And then from V2, the medial posterior superior nerve terminating in the nasopalatine nerve as it goes through the incisive foramen. What I forgot to mention in the in the picture at the top was that they're also the descending palatine, the greater palatine nerve and the lesser palatine nerve also came off of V2, and then they exit the greater and lesser palatine foramen to serve as the hard and soft palates respectively. As we begin to talk a bit about the submandibular area and the tongue, there are intrinsic muscles of the tongue that go in three directions. And then there are these extrinsic muscles of the tongue, like the styloglossus, which attaches on the styloid process in the tongue, the hyoglossus, which connects the hyoid bone to the tongue, and then genioglossus. Genio also refers to the chin, and so it goes from the internal part of the mandible and then to the tongue. The genioglossus is again shown here in cross section. As we think about the apex of the tongue, really is that most anterior part of the genioglossus. The superior longitudinal part here, those are those intrinsic muscles of the tongue, that one of the three intrinsic muscles of the tongue that I told you that go in three different directions. Deep to or inferior to the genioglossus is the geniohyoid muscle, which can be difficult to see from the submandibular or digastric triangles on the neck. So once we bisect the skull, that's usually where you get to see the genioglossus and the geniohyoid, particularly geniohyoid, which is superior to the mylohyoid, which you saw on the neck in the digastric triangle and submandibular triangles. Notice here, as we are talking about the tongue, so the intrinsic muscles of the tongue include this longitudinal muscle as well, right? And then the superior this is the middle constrictor is here, and you know that because the middle constrictor attaches to the hyoid bone. Notice that the hypoglossal nerve travels on top of the hyoglossus muscle. That's one way that you can find it. It travels on top of the hypoglossal nerve, travels superficial to the hyoglossus, and then dives deep to the mylohyoid anteriorly as it is moving towards the base of the tongue. In contrast, the lingual artery dives deep to the hyoglossal muscle. As it is diving deep to the hyoglossus muscle, it gives off dorsal lingual branches and then continues anteriorly as it gives off a deep lingual artery and sublingual branches. It is at the base of the tongue where you will encounter the sublingual gland, where the ducts of the sublingual gland open in the floor of the oral cavity. So again, the intrinsic muscles of the tongue are those three that go in different directions, a longitudinal and oblique one. Those are all innervated by the hypoglossal nerve, as are the extrinsic muscles of the tongue that we just talked about, the genioglossus, which is the main substance of the tongue, that fan-shaped muscle of the tongue, hyoglossus, which the hypoglossal nerve goes superficial to, whereas the lingual artery travels deep to, styloglossus, And palatal-glossus is also an extrinsic muscle of the tongue. However, it is innervated by the vagus nerve and is an exception to the innervation of the rest of the group. So in this image, the ramus of the mandible and the body of the mandible have been removed. So we're looking from superficial to deep through the jaw. Notice the genioglossus here. So what you can really appreciate here is the submandibular gland and the sublingual gland. Notice there isn't really a clear distinction between the submandibular gland and the sublingual gland on this picture. Superficial to that is the lingual nerve, which we saw in the infratemporal fossa, and hanging off of the lingual nerve is the submandibular ganglion. The submandibular ganglion is one of those four parasympathetic ganglia in the head. We've seen now ciliary, pterygopalatine, otic, and this is the fourth one, submandibular ganglion. The submandibular duct is here, and I'll show you in a second, where it enters into the oral cavity to empty near the second molar. The hypoglossal nerve is shown here in purple, going over the hyoglossus and diving deep to the mylohyoid, which is one way that you can distinguish the hypoglossal nerve in the neck. Now, the innervation of the submandibular gland, the sublingual glands, those are again parasympathetic. And so parasympathetic preganglionic fibers that originate with the facial nerve make their way through the infratemporal fossa via the chorda tympani, and then the chorda tympani joins the lingual nerve as those preganglionic fibers enter into the submandibular ganglion where they synapse, and then postganglionic parasympathetic fibers either jump back on the lingual nerve to ride to the sublingual gland, or they go directly to the submandibular gland. These are parasympathetic general visceral efferent fibers, GVE fibers. Notice that the parasympathetics of the facial nerve go to the mucosa of the palate, the nasal wall, they innervate the lacrimal gland, and also we've just talked about those parasympathetic fibers, preganglionic parasympathetic fibers of the chorda tympani that's part of the facial nerve, innervating the submandibular gland and sublingual glands. This picture is a picture from so the oral cavity has been bisected, the genioglossus has been cut. Here you can appreciate the geniohyoid and the mylohyoid inferiorly, and this is so that you can see that submandibular duct internal or deep to the submandibular gland on the lateral side of the genioglossus. So here's our submandibular duct. The lingual nerve is kind of dancing along with it. The submandibular ganglia will be found in the same area. And then those parasympathetic fibers that innervate the sublingual gland and the submandibular gland came from the facial nerve, which we've already now talked about. So when we talk about, that gives us now the opportunity to talk about the teeth. There are two teeth. You have your baby teeth, which are deciduous teeth, and then we have those permanent teeth. Notice that those teeth are inside the maxilla, inside the mandible, forming the upper and lower teeth. Those teeth either cut, tear, or grind, and it depends on, so those incisors are the ones that cut, the canines tear, shown here in blue, and then those molars are for grinding. These are the deciduous teeth, and then the adult teeth are shown immediately next to those. The submandibular gland enters near the submandibular duct enters the oral cavity near the third molar on the inferior teeth or the mandibular teeth, and then the parotid duct near the second molar on the mandibular teeth. Now, you do have to know, and your dissector does describe the taste buds on the tongue. It talks about the dorsum of the tongue, but your notes don't really discuss that. And so I want to just really briefly bring to your attention the dorsum of the tongue. The anterior 2/3 of the tongue have a different embryological development than the posterior 1/3 of the tongue. The anterior 2/3 sensory innervation of the anterior 2/3 of the tongue would be via the lingual nerve off of the trigeminal nerve, and the taste would be via the chorda tympani. The posterior 1/3, however, in contrast, both taste and sensation are via the glossopharyngeal nerve, and the sulcus terminalis reflects the place where these two structures join that, again, were derived from two different places embryologically. 46 here, let's see, right here at the tip of this V would be this foramen cecum, and so this would be the place where the thyroid gland originated before descending embryologically to live in its final resting place on the anterior part of the neck. And so there are some clinicals that I'm not going to have time to talk about right now, but that are associated with that and the thyroid gland. So lymphatic drainage of the tongue, the posterior 1/3 of the tongue drains posteriorly to the superior deep cervical lymph nodes. That's not surprising. And then more anteriorly, the anterior 2/3, the middle portions of the tongue drain to the inferior deep cervical lymph nodes, whereas the more anterior portions will drain to those submandibular lymph nodes, which are superficial lymph nodes, and then eventually those submandibular lymph nodes drain to the inferior deep cervical lymph nodes. The submental lymph nodes also are superficial lymph nodes. They're part of that cervical ring of superficial lymph nodes at the base of the neck. The submental lymph nodes draining the apex of the tongue, then drain into inferior deep cervical lymph nodes. That's shown here. So here are submandibular lymph nodes, submental lymph nodes. They'll drain to these inferior deep cervical lymph nodes before draining into the jugular lymph trunks at the right and left venous angles. The jugulodigastric lymph node receives that the tonsillar drainage, right? So I mentioned the jugular digastric lymph node as in tonsillitis. That's where we can expect that that enlarged lymph node that's sore when you have strep throat, for instance, is an enlarged, usually jugular digastric lymph node that is a part of this superior deep cervical group. When we talk about the larynx, remember that the larynx is responsible for phonation. It is continuous with the trachea. And as we're talking about this image, this is a posterior to anterior view. The left side of the image has the mucosa intact, and the right side has the mucosa removed to allow you to appreciate the musculature that controls the pharynx. So here you have your pharyngeal constrictors, as well as those muscles of the soft palate that connect with the pharynx. And then more inferiorly, you start to get these muscles of the larynx, these intrinsic muscles of the larynx that we're going to talk about now. The inlet to the larynx is inferior or deep to the epiglottis, which is shown here by my pointer. So if we take a closer look at the larynx, you have the thyroid cartilage and cricoid cartilage. The larynx is about C4 to C6. And so you can expect that the thyroid cartilage is located more cranially. It sits upon, and it's open, the thyroid cartilage is open posteriorly, and it sits upon the cricoid cartilage, which is a full circle. It looks like a signet ring where the most pronounced part of the cricoid cartilage is posterior as opposed to anterior. They come together at a joint, and this joint allows the cricothyroid muscle, which sits on the anterior parts of these cartilages. When it contracts, it tilts the thyroid cartilage anteriorly to increase the tension on the vocal ligaments. Between the thyroid cartilage and the hyoid bone is the thyrohyoid membrane. Remember that the internal branch of the superior laryngeal nerve pierced the thyrohyoid membrane and provides sensation in the larynx above the vocal folds. The epiglottis is shown here. And then if we turn around and we look posteriorly, the cricoid cartilage is here. The arytenoid cartilages and corniculate cartilages sit on top of the posterior part of the cricoid cartilage. And then the thyroid cartilage sits anteriorly and is open posteriorly. The epiglottis is shown here, and then the hyoid bone will be located here. If we bisect the larynx, what you'll observe is that the vocal cords are located here in orange, and then so the true vocal cords are located in orange, and then the vestibular ligament, which sits superior to that, is considered the false vocal cords. They attach to the thyroid cartilage and the arytenoid cartilages, and it's the turning, sliding, and tilting of these arytenoid cartilages that changes the tension on these vocal ligaments, producing the changes in sound that we hear during phonation. So in this picture, you can appreciate that the vestibular folds are superior to that. So all of this area inside the larynx is covered in mucosa, and so when the vestibular cords are covered in mucosa, it's referred to as the vestibular fold. The vocal fold is here where the vocal ligaments have been covered in mucosa, and that's shown here. The space between the vestibular fold and the vocal fold is the ventricle, and it's basically an invagination of the space between those vocal cords as those mucosa layers envelop them or cover them. So here are the vestibular ligaments covered in mucosa. So this is the vestibular fold, and here is the vocal fold. Number 5 here would be the vocal fold. Notice that the vestibular ligaments are, and vestibular fold is superior and lateral to the vocal ligaments, and that becomes important as we are looking at this area through a scope. The ventricle is shown here, that space between those two folds, and then the trachea is located here. So as we take a look through our rhinoscope, right, or to the larynx, what we see is the epiglottis superior. So this is a superior to inferior view through the larynx, and the epiglottis is shown here, and the tongue would be anterior here. So this is anterior, this is posterior. The vestibular folds, again, are superior and lateral, and it can be difficult to appreciate this ventricle that lies between the vestibular fold and vocal folds in this particular image. The vocal folds are more medial, and when this space or opening is the rhoemoglottis, and when we're talking about the vocal folds plus the opening, we're talking about the glottis. There are folds of mucosa that connect those arytenoid cartilages to the epiglottis, creating these aryepiglottic folds. And then posterior to that here would be those piriform recesses where foodstuff from the tongue would be, the epiglottis would go down to cover the airway, and the foodstuffs would then move around these piriform recesses to gain access to the esophagus. Here is another laryngoscopic view, and so in this picture the epiglottis is here, so this is anterior, so the tongue would be here, and the esophagus would be here posterior, and the piriform recesses would be the pathway to the esophagus. The arytenoid cartilages are deep to this mucosa, and then those folds, mucosal folds connecting it to this epiglottis would be these aryepiglottic folds. The vocal folds are here, and the vestibular folds are lateral to that. So the muscles that act on the larynx, the intrinsic muscles of the larynx, facilitate the turning, sliding, and tilting of those arytenoid cartilages as they sit upon the cricoid cartilage. and they are all innervated by the recurrent laryngeal nerve, particularly the inferior laryngeal branch of the recurrent laryngeal nerve. The arytenoid cartilages are shown here, so here, and then you can't see the other one, but the interarytenoid muscles attach on the lateral sides of the arytenoid cartilages, causing the arytenoid cartilages to squeeze together, closing the rima glottis. So closing the space between the vocal ligaments. The posterior cricoarytenoid muscles attach on the lateral parts of the arytenoid cartilage, and they turn the anterior parts of the arytenoid cartilage. They are the only ones that open the rima glottis because of how they are positioned, how the attachment of these posterior cricoarytenoid muscles are positioned on the lateral sides of the arytenoid cartilage. So they're the only ones that open the space between the vocal ligaments. Here is a picture from Rowan, and you can see those oblique and transverse fibers of the interarytenoid muscles, and here's the posterior cricoarytenoid muscles shown here. You can also see the recurrent laryngeal nerves headed back up. Remember that branches of the recurrent laryngeal nerves, particularly the inferior laryngeal branches, they innervate the intrinsic muscles of the larynx. The cricothyroid muscle is considered, however, an extrinsic muscle. Well, it is an extrinsic muscle of the larynx. It's innervated by that external branch of the superior laryngeal muscle that we saw previously when we discussed the internal laryngeal branch. The external laryngeal branch innervates this cricothyroid muscle, tilting the thyroid cartilage anteriorly to increase the tension on the vocal folds, so that it's equivalent to like squeezing the opening to a balloon where you want to make it scream. The thyroarytenoid muscle sits inside of the larynx, attaching from the arytenoid cartilages here and the thyroid cartilage on the inside of the thyroid cartilage. It's contracting, decreases the tension on the vocal folds. The most internal part that lies directly on the vocal folds would be the vocalis muscle. You will not be able to see that vocalis muscle on gross dissection, but you will see the thyroarytenoid muscles sitting on the vocal folds. The lateral cricoarytenoid muscles turn these arytenoid cartilages, so they pull on these laterally, which causes the rima glottis to close. And so that's the lateral cricoarytenoid muscle. So here again, a vagus, and all of these, the larynx, both sensory and motor, these are all innervated by a branch of the vagus nerve. And so I'll talk about that in a second. The arterial supply is via the common carotid, and then the external carotid branch gives off the superior thyroid branch. The superior thyroid branch gives off a superior laryngeal artery, which pierces the thyrohyoid membrane with the internal laryngeal nerve. That's the landmark there, that thyrohyoid membrane. So that's where the superior laryngeal artery comes in. The innervation of the vagus includes the superior laryngeal nerve as it branches into an internal and external branch. The internal laryngeal nerve pierces the thyrohyoid membrane to provide sensory innervation to the larynx above the vocal folds. The external branch then innervates the cricothyroid muscle, which tilts the thyroid cartilage anteriorly. And then the rest of the intrinsic muscles of the larynx are innervated by a branch of the recurrent laryngeal nerve. Particularly, it undergoes a name change to the inferior laryngeal nerve as it passes the crico, as it goes posterior, the inferior border of the cricoid cartilage. It changes names from recurrent laryngeal to inferior laryngeal. You may see some sources that differ on that. They may just call it the recurrent laryngeal branch. But if inferior laryngeal is an option, that is a more specific way to identify those muscles of the those nerves that innervate the intrinsic muscles of the larynx and provide sensory innervation below the vocal folds. And again, I'm just highlighting for you that these are sensory, inferior laryngeal sensory below the vocal folds. Usually those muscles are the innervation of the intrinsic muscles of the larynx could be attributed to the inferior laryngeal nerve or the recurrent laryngeal nerve. And finally, when we are talking about the larynx and the lymph drainage of the larynx, you have pretracheal, paratracheal lymph nodes. There's also a prelaryngeal lymph node that's not shown on this particular image. Those drain laterally to the inferior deep cervical lymph nodes that are associated with the internal jugular vein, and then through the jugular lymph trunks to the right and left venous angles. And then that shows you the same thing. On this image, however, it does show you the prelaryngeal lymph nodes. They'll drain to the superior deep cervical first, and then the inferior deep cervical. Regardless, they all go to the inferior deep cervical before entering the jugular lymph trunks.